I already talked about me and Eric and Linda and Amy, and now I get to introduce our speaker, Mary Phillips. So we were introduced to Mary by Dr. Sinead Duggan from Trinity College Dublin. Dr. Duggan had been brought in to speak to pancreatitis experts at an international conference last summer about the latest research on diet and nutrition for pancreatitis patients. And when we followed up with her, she introduced us to Mary Phillips. Together, they developed a curriculum to teach health professionals about diet and nutrition for pancreatitis, which they've been teaching all across the UK and Europe. Mary is also an author of multiple nutrition and treatment guidelines for chronic pancreatitis in the UK and Europe. So we're really lucky to have Mary here to share her expertise and to answer your questions. Mary, welcome.
Lovely. Thank you so much for the kind invitation to speak to you today. I hope this session will be valuable to everybody. So as Megan said, I am a pancreatic dietitian. So I work in Guildford, which is slightly southwest of London, and I work at a tertiary pancreatitis centre. So this means we specialise in managing pancreatitis and pancreatic cancer across quite a large region within the UK. And I've been very privileged over the last 20 years to develop some fantastic working relationships, which has allowed us to run a national programme which supports non-specialists in managing people who have pancreatic conditions. And that is because the way our healthcare setup works within the United Kingdom, there are only 22 pancreas centres across the whole country. And so as a result, the vast majority of people with pancreatitis will be managed by non-specialists. Consequently, we have a real need to train those non-specialists to recognise problems associated with pancreatitis and also to know who to speak to when they need help and how to access help. So at the moment, our training session has been running for just on 8 years now, and we've trained 1 in 8 registered dietitians within the UK, so which doesn't sound like a lot, but it's just over 1,200 people. So hopefully it's making a difference. So anyway, moving on from that, I am privileged to be talking to you all today about nutrition in chronic pancreatitis. So if I could just have the next slide. So just before we begin, the most important thing, and I'm sure you all know this from talking to each other and other people with pancreatitis, that everybody's situation is completely different. So the more we look into nutrition, the more we realise that everybody has very different needs, and consequently some of the information in this presentation may not seem applicable to you, and certainly what I don't want anybody to do is to change their management without speaking to their managing consultant. If there's any questions, obviously do put them in the Q&A and we'll try our hardest to answer as many as we can at the end. So next slide, please. Perfect. Right, so why I focus on nutrition? So I'm a dietitian, I'm a little bit biased. Nutrition is always going to be my priority. What we're going to cover today is some of the common nutritional challenges for people with chronic pancreatitis. We know that malnutrition is prevalent, and we know that anything up to 5% of people with chronic pancreatitis are likely to need some form of artificial nutrition, typically in the form of tube feeding. We know that exocrine pancreatic insufficiency is also common, and that is because of an inability of the pancreas to produce sufficient digestive enzymes. And I'm going to talk more about that in a minute, and I understand you've had separate webinars on that in the past. And then the other factor that we almost must consider is the presence of diabetes, particularly type 3C or pancreatic diabetes. And for people with chronic pancreatitis, there is an 80% lifetime risk of developing this. So 4 in 5 people will develop type 3C diabetes at some stage in their journey with pancreatitis. And next slide, please. So first of all, in order to understand how we manage malnutrition and nutritional problems in pancreatitis, it's really important that we understand where they come from. So initially we have fibrosis or calcification of the glands. So this is the scar tissue that forms in chronic pancreatitis. And this tissue gradually replaces the healthy tissue within the pancreas. And at the same time, stones form, so calcification. And those stones also form within the tissue, but also they can block the duct from the pancreas where all the pancreatic juices drain. And this leads to 4 very specific nutritional aspects. So one, when there's a less than 5% of functioning pancreas, we see diabetes, and we will see a gradual progression of diabetes in most people. So it's not necessarily a straight onto insulin, so often diabetes will gradually progress. We see exocrine pancreatic insufficiency as the digestive function of the pancreas struggles, and this can cause diarrhea. And we see worsening pain. And typically, as people's pain escalates, so does their requirement for opioid-based painkillers. And we also see something called duodenal stenosis, which is thickening or hardening of the duodenum around the pancreas, and this causes the stomach to delay in its emptying. And both that and the opioid painkillers cause nausea. So whilst we've got diarrhea and nausea already running, the diarrhea results in food avoidance, we see fatigue, and we see delayed gastric emptying because the stomach can no longer function properly. And all of these things combined result in poor oral intake, and the diarrhea leads into malabsorption as well, and these things accumulate into malnutrition. So in order to manage the malnutrition, we do need to manage all of the other factors involved in contributing to this. Thank you. Next slide, please. So why do we have a problem with malnutrition and malabsorption? Well, ultimately, an injured pancreas can't digest normally, and we see that predominantly with fat maldigestion. Now, the pancreas is also involved in digesting carbohydrates and protein as well, but it's less easy to see when we're not absorbing those properly. When we don't absorb fat properly, we get very classic bowel symptoms. So people will often experience steatorrhea, so oily stool, and that is very classic of fat malabsorption. Protein and carbohydrate is more difficult to detect, but alongside that we'll also see deficiencies in fat soluble vitamins. You need to be absorbing fat properly and having enough fat in order to get adequate vitamin and mineral levels as well. Thank you. Next slide. Perfect. So I'm not going to dwell a huge amount on exocrine pancreatic insufficiency because I know there's been separate webinars on this, but ultimately in chronic pancreatitis, EPI is progressive. And we have to be a little bit careful how we interpret the data here, because making the diagnosis of chronic pancreatitis is often delayed. So whilst the studies suggest that exocrine pancreatic insufficiency might not be that common in the early stages, most people have had pancreatitis for many years before they ultimately get a diagnosis. But the upshot from this is that not only is the progression on to developing exocrine pancreatic insufficiency change with time, but also the severity of insufficiency changes with time as well. And that means people often need to increase their enzyme doses as time progresses. The effects of exocrine pancreatic insufficiency do vary from person to person and will depend on how well controlled they are with enzymes, how effective the enzymes are for them, and how their general nutritional state is. But ultimately, we see a high potential for long-term vitamin and mineral deficiencies, particularly surrounding the bones, and the prevalence of osteopenia and osteoporosis due to poor absorption of vitamin D and calcium. We see malnutrition with weight loss and sarcopenia, which is the loss of muscle function. And we see a higher instance of cardiovascular disease in people with untreated exocrine insufficiency. And we think that's because of the relationship between HDL, that healthy fat, healthy cholesterol that runs through your bloodstream. But we're not entirely sure on the mechanism of that yet. We just know that there is a higher instance of cardiovascular disease in people who don't have their exocrine insufficiency treated. So if we can get on top of enzyme treatment and we can get it right, we can often reverse the vast majority of these problems. Now, the biggest issue we have with exocrine insufficiency is that the healthy pancreas is stimulated by a complex 4-step physiological process. that is ongoing throughout the whole process of digestion. So it starts as soon as food enters your mouth or is in vicinity of you, with it stimulates by taste and smell of food. You then have a peak in pancreas secretions as your stomach stretches and fills with fluid. But the most important part of it is the change in pH, which is the acid levels in your stomach, as the partially digestive foods drop into the next section of your bowel called your duodenum, and that stimulates your pancreas over a period of 2 to 3 hours after eating. And then further down the bowel, there's essentially an off switch when partially digested foods get to your ileum, your small bowel. That's a really complex physiological process. So trying to mimic that with a tablet and set doses of tablets means we never get it 100% right. So it's really important that we try and optimize enzymes to get it as close as we possibly can. And when we do that, we can often reverse the malnutrition, reduce the risk of things like cardiovascular disease and osteoporosis, and help manage those vitamin and mineral deficiencies. Thank you. Next slide. So moving on to the diabetes side of things, so this, like exocrine insufficiency, is the other aspect of the pancreas that fails when it's not functioning properly. And people will develop diabetes at different times and at different severities. So some people may have early signs of diabetes quite early on that they can control with dietary modification. Other people may need to take tablets, and some people will need to take insulin. The rate of progression onto insulin is much faster in type 3C diabetes, so pancreatic diabetes, than it is in type 2 diabetes, which is obviously more common in the general population. The symptoms that might suggest your blood sugars are running very high are related to your fluid balance, essentially. So when you have a lot of sugar in your bloodstream, your kidneys try to help by filtering it all out in your urine. And what that does is it makes your urine very concentrated. So your kidneys then try to dilute that, which makes you very thirsty. It means you pass a lot of urine. Often people tend to notice when they have to start getting up in the night to pass urine many, many times rather than just maybe once. So people will have a dry mouth, lots of thirst, and because they're losing the sugar from their body via their urine, they're not metabolizing it, then they'll often lose weight as well. So if you develop any of those symptoms, it is really important that you go and have your sugar levels checked with your primary care physician. So like I mentioned earlier, treatment varies from medications that might be tablet form up into insulin, and we just have to be careful with the simple sugar version of a part of food. So simple sugars will cause your blood sugars to peak very quickly. But this type of diabetes is different to type 2 because you don't have the reserve of glucagon, which is the hormone that does the opposite of insulin, that's also secreted by your pancreas, which means that what glucagon normally does is control your blood sugars in periods of fasting. So for instance, when we're asleep overnight and we go for 10, 12 hours without eating between your evening meal and breakfast, glucagon is the hormone that stops your blood sugars from dropping during that time. So it actually stimulates your liver to produce more sugar. That hormone is also made by your pancreas, and this is the main difference between type 2 and type 3C diabetes, that the glucagon is missing as well. So what that means is the other important factor of managing diabetes is that you avoid periods of starvation. So bedtime snacks are really helpful, and avoiding missing meals is really, really useful as well. The management of this is really important to prevent long-term complications associated with poorly controlled diabetes. When your blood sugars run very high for very long periods of time, it causes damage to your blood vessels, and we tend to notice that in your peripheries, so your fingers and toes, in your eyes, your kidney, and around your centralized blood system. So it is important that we recognize diabetes early and that we treat it. Thank you. Next slide, please. So how often should you be tested and what for? So this varies dependent on which issues you already have present and which we're just looking out for and screening for. So as I mentioned before, if you had any of those symptoms of diabetes, don't wait for an annual test. You need to go and have that checked now. But generally speaking, your fat-soluble vitamins should be tested once a year. We do test those more frequently if we're having to correct them, but otherwise once a year should be sufficient. You have extensive body stores of some of those vitamins, so it can take quite a while for a deficiency to show. Liver functions and HbA1c, so this is a long-term marker of your sugar control. Those should be tested once a year. And your bone mineral density, so this is looking for any early signs of osteoporosis, so we can jump in quickly and treat it and prevent it from getting any worse. So that's typically carried out in the form of a DEXA scan, which is a bone mineral density scan, and those should be carried out approximately every 2 years. And on top of that, you have a standard lipid panel for triglycerides and cholesterol and everything that's carried out once a year. Thank you. Next slide. So in terms of what we recommend for the management of chronic pancreatitis, there are different recommendations dependent on what symptoms are bothering you the most and where we're at in terms of your management. So the question about low-fat diet comes up every time, and I'm going to talk a little bit more about that in a minute. Pancreatic enzyme replacement therapy, so the enzymes that you take to treat exocrine pancreatic insufficiency, those are crucial to managing normal digestion and preventing malnutrition. Nutritional supplements vary dependent on the type that you need. So some people might just need a vitamin D supplement or a multivitamin and mineral. Other people might need liquid nutritional supplements to provide extra energy and extra protein. And ultimately, some people will require enteral feeding. So enteral feeding is the provision of artificial nutrition directly into the gut, bypassing the process of eating. And there are lots of different ways of doing that. And this diagram on the right-hand side demonstrates them. So the least invasive is a nasogastric tube, which is a tube that goes down your nose, down the back of your throat, into your stomach, and feeds into your stomach there. Sometimes we will use a nasojejunal tube, which is the same process, but it goes down past your pancreas into your small bowel, and that can be very useful when there's problems with your stomach emptying. So if you have this duodenal stenosis, this hardening of the duodenum underneath, and some people will find in high dose opioids or with a problem with very poorly controlled diabetes that your stomach doesn't empty as well either. And feeding into the small bowel can be very helpful to manage nutrition in that situation. You then have what we call percutaneous tubes, which are tubes that go through the skin. So these are more long-term. So you can have a tube that goes directly into your stomach, which is a gastrostomy tube, or you might have heard them referred to as PEG tubes. So that refers to the specific type of procedure that those are placed in. So it's an endoscopic procedure. So PEG stands for percutaneous, which means through the skin. Endoscopic, which is the tubes used to site them, and gastrostomy, which is a hole forming into the stomach to allow us to feed. We then have jejunostomy tubes, which are typically placed during an operation, and they allow us to feed into the small bowel, the jejunum, in a more long-term manner. And then finally, we have intravenous nutrition. Now, it's very rare to need this in chronic pancreatitis, but very occasionally it is necessary. And this is where we feed people directly into the bloodstream. So this uses partially digested foods. That sounds a bit awful. It's not actually been digested, but the food's been completely broken down into tiny particles, and that's absorbed directly into your bloodstream and bypasses the digestive tract completely. Next slide, please. So what about fat? I promised I'd come back to this. So this is probably the most contentious issue in all of management of pancreatitis, and guidelines are very different in the UK to what they are in the US. So ultimately, some people are intolerant to fat. For some people, it can trigger flare-ups of pancreatitis. For some people, it can cause worsening abdominal symptoms. It can cause fecal urgency, so needing to get to the bathroom very quickly, and profuse diarrhea. But there are lots of different factors that are involved in tolerance of fat. So it is always worth excluding what we call modifiable factors, so things we can actually fix. So the first thing always to consider with fat is if your symptoms are worse with fatty foods, are you having enough enzymes with them? People who don't have enough enzymes with fatty foods will often have bowel symptoms, and that can be reflux and gurgling through to crampy abdominal pains and diarrhea. Typically with very high fat foods, the diarrhea is yellow and oily and difficult to flush away. There's often a lot of wind and bloating that accompanies it, and it will be very, very unpleasant. So the first step is to increase enzymes to make sure that that's not the reason you're not absorbing the fat properly. The other things to consider is something called bile salt malabsorption, which is more likely if you've had your gallbladder removed, but this affects the flow of bile from your digestive tract, and that can mean that you don't digest your food properly. Bile is essentially your washing up liquid of digestion. It allows fat and water to mix. So without bile that's produced by the liver, the whole manner in which fat is digested changes. And that can cause symptoms very similar to not having enough digestive enzymes. You can also get small intestinal bacterial overgrowth, particularly if you've had an operation for your pancreatitis, the pancreatic duodenectomy or Whipple operations, or a Frey or a Pusto procedure. You'll have a loop of bowel that food doesn't pass through. And that is susceptible to the bacteria in it overgrowing. So we call it bacterial overgrowth. But it can occur in people who haven't had surgery as well. And what that means is that the gut flora has changed. So the type of bacteria within your bowel has changed. And that can precipitate out the bile salts. It can make enzymes less effective. And those three things can often occur as a little bit of a triad. It's treated with antibiotics, and there are breath tests that can be carried out in order to test for it. So it is absolutely worth, if you're still having ongoing symptoms, going back to your gastroenterologist and making sure that other things that cause these problems are excluded. And then when it does come to fat, just remembering that we have some fats that are better for us than others, and for our long-term health, we should be trying to avoid some of the saturated fats and trans fats on the picture on the right. And if we are reintroducing fat, that we should probably start with the healthier fats, monosaturated and polyunsaturated fats, and gradually build up. There are some people who tolerate fat in its entirety, and certainly in the UK we don't restrict fat unless people have a problem with it. The clinical studies that have looked at the impact of fat have shown that people who have fattier diets are more likely to develop chronic pancreatitis, but there are many, many other factors involved. That is just one. But in terms of fat tolerance with chronic pancreatitis, there is actually only one study that looked at a group of people who had chronic pancreatitis in India, and they were predominantly a vegetarian population, and they gave them high energy and nutritional supplement drinks, and they also gave them high energy dietary advice. And because of the vegetarian nature of their diet, the most effective way to increase the energy levels in their diet was to use vegetable oils and dairy products. So by default, they increased the fat content. And in that group of people, they demonstrated that pain was better controlled, people needed less pain relief, malnutrition was reversed, and there weren't significant side effects. But extrapolating that data into a US population and different dietary intakes and different causes of pancreatitis is not straightforward. So the ultimate answer is there isn't a clear one answer fits everybody for this. It is very individual. So we try with fat. If you don't tolerate it, we look for other causes. That means you might not be tolerating it, because we can often control those and give you a lot more dietary freedom. But there are a group of people for whom fat is a real problem, and then we need to make sure that we've got enough fat soluble vitamins and that we have enough calories and protein going in, because fat is our most energy dense source of calories. So it has more per gram, it has twice as many calories in it as carbohydrates and protein do. So fat is something we need to absolutely consider. Next slide, please. So in general, there are lots of different signs and symptoms that can adversely affect nutrition, and it's important that we manage those. So nausea and vomiting, as I alluded to earlier, can have a multitude of causes. So some people will develop pseudocysts that can press on their stomach. Some people will have this duodenal stenosis. Some people will have nausea due to the opioids that they take and that they need. And there are lots of other factors contributing to it. So the first things first with nausea and vomiting is we look for the cause. We work very closely with the rest of the multidisciplinary team to optimize anti-sickness medicines. And we try and encourage people to eat little and often so their stomach isn't overly full. Some people find greasy and spicy foods more likely to cause a problem. Avoiding periods of starvation can help as well, and some people will find that cold foods are more easy to tolerate than warm ones, and a lot of that we think is to do with the food smells. So avoiding food smells can be helpful. When it comes to poor appetite, which can often be associated with nausea and vomiting, but also associated with pain on eating, or simply just a poor appetite in itself. Again, eating little meals spread out throughout the day, simple things like separating your pudding from your main course. So having your main course and then maybe leaving it an hour and coming back and having pudding, not forgetting to take your enzymes with both of these now, so we have to treat them like separate meals. Making sure we get plenty of rest. We're not overexerting ourselves, but conversely, small amounts of regular exercise often help stimulating appetite as well. So it's getting a balance right in there. When we focus on unplanned weight loss, it's really important that we talk to your doctor to make sure we know why you're losing weight, because we need to make sure that something like diabetes hasn't appeared and is resulting in that weight loss. So it's always important that we don't just try and manage a new weight loss without finding out what the cause is. But in this instance, we might use food fortification, so using really high energy, high protein foods, and then moving on to using things like oral nutritional supplement drinks that are high in protein, high in calories, to try and replace the nutrition that's missing from food. And then ultimately, in a very small number of people, we might need to use artificial nutrition in the form of a tube feed. Hydration is important for lots of reasons. So dehydration is associated with worsening pancreatitis in some people, but also particularly if you're taking a lot of painkillers and you're very prone to constipation, dehydration will worsen that as well. And we can see a huge amount of abdominal pain associated with that constipation and dehydration. So trying to make sure that we are optimizing hydration where we possibly can and using nutritious rich fluids. So rather than drinking water, if you're struggling with eating and drinking, something like skimmed milk is really high in protein, very low in fat, and will mean that you make the most out of your fluids when you are drinking them if you're struggling with a poor appetite. Conversely, if you're managing to maintain your weight well, and you not having adverse signs and symptoms, then a normal healthy eating diet is recommended. So reducing your saturated fat, plenty of fruit and vegetables, lots of regular exercise, and all of this is a benefit for your long-term health. Thank you. Next slide. So I'm going to finish my presentation there and hand over to Eric. So thank you for listening, and I'll be back in a minute for some questions. Thank you.
Yes, thank you, Mary. Extremely helpful. As Megan said, I'm Eric Golden. I co-founded Mission Cure along with Megan. I was diagnosed with chronic pancreatitis about a dozen years ago, and from the beginning, nutrition has not only been something that has caused issues, but also a real source of confusion. So, Mary, this is extremely helpful. We've gotten a lot of really good questions. We're going to start with a few that were submitted ahead of time and then move on to the ones that were covered today. And if for some reason we can't get to a question, we'll try our best to respond by email. So the first question is, what can I do or take to relieve or prevent bloating and gas when taking digestive enzymes?
Thank you. So bloating and gas is really common in chronic pancreatitis, and there are lots of reasons associated with it. Not having enough enzymes can cause bloating, and to understand why we have bloating is really important to get how we might manage it. So bloating is typically caused when things ferment in your bowel, and they produce a gas, and that's when they're exposed to bacteria. So we see bloating with constipation, You'll see a lot of wind with that, and that's because the fecal matter is in your bowel for longer than normal. It's exposed to more bacteria, and it ferments at a higher rate, producing a lot of gas. You'll also see bloating and gas formation with gastritis, so when the stomach lining is irritated, and that's also common in chronic pancreatitis, and that's why a lot of people are taking medicines to reduce the acid content in their stomach, drugs like omeprazole, lansoprazole. So first things first is to look at why you're bloated. So have we got enough enzymes in? Are the enzymes, one of the side effects of enzymes is constipation, are they contributing to that? And if you're really struggling with enzymes, then we should try a different product. Oh, sorry. We should try a different product to make sure that we don't have an adverse reaction to one particular product. So a few stepwise things to do: make sure you're drinking plenty at the same time. So lots of fluid will help as well.
Terrific. Next question is, if I take an enzyme and then get sidetracked and don't eat immediately, will it cause any problems with my stomach or intestines?
So it won't cause any problems, but it will mean that you need to take enzymes again when you do start eating, because they won't work. So as soon as they've left your stomach, they won't do anything. So you need to, when you do get back to eating, then you need to take a second dose of enzymes. And
actually, the follow-up question we had was, how long in advance do you need to take the enzyme? So if I wait and then eat again, at what point do I need to take them again?
Good question. Everyone is a little different for that. So to understand why you need to take enzymes and at what time, understanding how enzymes work can help with this. So the capsules that your enzymes come in, the coating of those is designed to dissolve within stomach acid within 1 to 2 minutes. Once the capsule dissolves, the granules inside are designed to disperse in food as it churns in your stomach. So as soon as food goes into your stomach starts contracting and churning that food up and breaking down all the major structures within it. That's the point you want the granules dispersing in, because those granules act directly on the food they come into contact with. So in order to get your enzymes to work as optimally as possible, you should take your first capsule, assuming most people are taking more than one. You take your first capsule at the beginning of your meal, literally with your first mouthful of food. If you take the enzyme too early, your stomach acid will open the capsule up and the enzymes will all sit in stomach acid. There isn't anything else in there. They get exposed to all of that stomach acid, and the acid will denature them, so it destroys the enzymes. If you've got food in your stomach at the same time, then the pH, the acid levels are lower, because your food is typically alkaline, and neutralizes your stomach acid. So then as the food leaves your stomach, the enzymes are activated when the pH changes and they digest your food. So for most people with normal stomach emptying, your stomach empties within 15 minutes of you eating. So that means if you're having, say you're dining out in a restaurant, you have a starter and then a main course and then a pudding. These will all typically be more than 15 minutes apart. So you should take your enzymes with each course. And with the larger dishes, and that might be puddings as well, or even a rich starter, taking 1 or 2 throughout that will also help. If you forget and you get to the end of your meal and you realize you've forgotten your enzymes, you can take them right at the end of the meal. They might be less effective, but they might still do something. And that's better than nothing. Does that make sense?
That's terrific. Yes, thank you. Here's a question that involves a little more than just nutrition. If I have an occasional glass of wine or another alcoholic beverage, should I take a digestive enzyme with it?
And appreciating you might have people with different pancreatic conditions in here, but for chronic pancreatitis, we would always recommend, regardless of the cause of chronic pancreatitis, that you do avoid alcohol. So for those people who take enzymes for other pancreatic conditions and who can consume alcohol, the vast majority of them don't require pancreatic enzymes with them. The snacks that you have with them will. So the only caveat to that is alcoholic beverages that contain milk. So things like Baileys and Irish cream, you're likely to need an enzyme with those. But otherwise, things like wine and beer and cider, you don't need to take enzymes with those.
One of the questions that came up live, how do I know how much pancreatic enzymes to take, as well as how to adjust that dosage as my conditions change?
That is the question that if I could come to the answer to would mean I could retire, I think. So it is the most difficult part of managing chronic pancreatitis, in my opinion, in terms of getting everything right for the individual at that right time. And the closest analogy I can give to it is it's like managing insulin in diabetes. Every patient needs a different dose for a different meal at a different time. And sometimes it can be really, really difficult to get on top of that. But ultimately, the important thing is to look at how you respond to the dose that you're taking. So if you start with one dose and it doesn't work, but it does something, then absolutely we should increase it. And when you reach the stage where increasing your dose hasn't made any difference, that's we know when we've got as far as we can go with that dose. We need to make sure that we have distributed the enzymes properly and that we're making them as effective as we can, though that's really important too. So what I would say is don't be afraid to increase your dose, but if you reach a stage where increasing your dose doesn't make any difference, that's the point where we need to stop. And then as things change, for some people with chronic pancreatitis, they can be on the same dose of enzymes for 10 years, 15 years. For other people, it can be 2 or 3 years by symptoms. If your abdominal symptoms return, if you're struggling to gain weight, or you're losing weight, or you just don't feel quite right, or you're starting to have problems with vitamin and mineral deficiencies, those would all be triggers for us to start increasing enzymes and to see whether that helps.
Terrific. Well, there've been a lot of questions about enzymes. Another live question is, what do you suggest for someone who's unable to tolerate digestive enzymes?
So that's a very difficult situation to be in. We also, because of the porcine nature, so being derived from pigs' pancreases, do have people who really struggle with taking enzymes. And that is a very difficult situation to manage. At the moment, we have we have no real options outside of that. So there are some techniques for people who are allergic to the enzymes to try and desensitize to them using very small doses, tiny doses alongside antihistamines, and gradually trying to build up a tolerance to enzymes. So we have done that on a couple of occasions to try and build tolerance to them. Changing how you take the enzymes and which preparation you take. There are lots of preparations, and it is absolutely worth trying all of them, because sometimes the problem lies more in the coating rather than the enzymes themselves. But a lot of products will use very similar coatings, which is why you can see the same problem with different products. But it is absolutely worth trying all of them. If you really can't manage any enzymes at all, then managing your symptoms using a very low-fat diet can help, but that won't help with the absorption side of things, and malnutrition can still be a problem. And that's where using some of the elemental or semi-elemental nutritional supplements can help, because those enzymes have already been exposed to, those products have already been exposed to enzymes in the production process, but those enzymes have then been filtered out. So they've had the benefit of the enzymes without the enzymes still being present. So they can be helpful in that setting. And you need to speak to your gastroenterologist or dietitian about that.
Is there evidence that digestive enzymes can help for people who do not have enzyme insufficiency? So it may help with pain or digestion, even though the enzymes aren't needed to replace missing ones?
Yeah. So there's been quite a few studies looking to see whether if you take enzymes by mouth, it inhibits the pancreas and stops it working so hard. And that's the mechanism behind the thought that there may be an improvement with pain control for people where we try and essentially switch off the pancreas doing that. Unfortunately, in clinical trials, that's not been proven. So they've carried out a number of trials looking at the amount of opioids people need, about pain scores, and a lot of these have been blinded studies as well. So using enzymes and then also using identical capsules, but not containing enzymes. So people aren't aware of what they're taking. And the studies really don't, unfortunately, show a benefit. So theoretically, I think a lot of people have been quite enthused that that may help, but unfortunately the studies don't seem to support that.
Understood. There have been a couple comments that you've made about weight loss. There have been a few questions about weight gain. So I think I'll pose a couple of them to you and let you answer as you see fit. The first one is simply somebody with recurrent acute pancreatitis said they have gained weight over the last several years and want to know if this is something that you have heard of. And the second question is, have you heard that enzymes may increase appetite? And if so, how do you deal with possible weight gain?
Okay, so in terms of weight gain, so the enzymes, I'm going to answer the second question first, if that's right. The enzymes, in terms of stimulating appetite, they correct nutrition, and one of the side effects or symptoms of malnutrition is poor appetite. So by correcting that, you can seemingly stimulate the appetite more back to a normal stage. And we manage weight gain in that situation in the same way as we would for anybody who didn't have pancreatitis. So by looking at reducing portion sizes, regular exercise, and trying our hardest to manage that. A lot of the problems we see with weight gain in recurrent acute pancreatitis as well as chronic pancreatitis are usually due to the effects of pain on mobilization and making it difficult for people to exercise like they would do normally. And break down the food and use it for energy like you would normally do. So it can mean sometimes that we have to be quite tight with portion control to try and prevent significant weight gain during that stage. It's a very difficult situation to be in.
Thank you. Are there any symptoms of bacterial overgrowth that are different from chronic pancreatitis that patients should be aware of or be on the lookout for?
Good question. So with bacterial overgrowth, it manifests itself in two ways. So it will cause symptoms within your bowel, and those symptoms are identical or a part of the symptoms of exocrine insufficiency. So they are bloating and excess wind and more frequent bowel motions. So it's almost impossible to tell those apart. If you've got bile salt malabsorption or bacterial overgrowth and you're increasing your enzymes and it's not making a difference, that's the point we would start looking for it, because if those symptoms are progressive without any impact from increasing the enzymes, then we know we're looking for something else. So that's the point where we would start looking. The symptoms itself are virtually impossible to tell apart.
I see. Another person asked, can you talk briefly about the differences between the US and UK approaches on fat? Does one tolerate or recommend more than the other?
So my understanding is in the US, fat restriction is used much more commonly. In the UK, it's not first line management at all. We only use fat restriction if people are struggling to tolerate fat. And in fact, for the vast majority of people, a relatively high energy, high fat diet for malnutrition associated with chronic pancreatitis is our first line treatment. So that is, I understand, quite different to what is recommended in the US.
I see. Another question is, should patients take antacids or omeprazole at the same time as enzyme replacement therapy or earlier to combat the effects of stomach acid on the enzymes themselves?
Good question. So the medicines they use to treat or reduce stomach acid, they typically work for 20 to 24 hours. So long as you've taken them each day, that should be absolutely fine. The timing of them isn't important, aside for the fact you should take them at the same time every day. So whether some people recommend taking them in the morning, others in the evening, doesn't really matter. So long as you're consistent and you take it at the same time every day.
Here's a question I'm very interested in as well. Are there foods that you would recommend that are nutrient dense but are low fat? I know you mentioned that fat is an important source of energy and certain nutrients. What do you recommend instead?
So when it comes to people who are needing to follow a fat restriction, like I mentioned earlier, it can be really difficult to get enough calories in that situation. So looking for really high protein food sources instead. And to give you a comparison of food products with fat content, things like skimmed milk compared to a full cream milk. So a pint of skimmed milk has 20 grams of protein, which is a really nice quantity of protein, but it has less than a gram of fat in the whole pint. So that can be really useful. Using skimmed milk powders to add into other desserts can add in that extra protein without having the liquid volume of milk. Often we find when people are really struggling, actually the volume of food is problematic as well. Things like scrambled eggs made with egg white on its own, rather than using the yolk, reduces the fat content, but you still keep the protein in, and you've got nearly 4 grams of protein in each egg. So using an egg white along those lines. Lean cuts of meat and fish, things like a tin of tuna in brine, so it's salt but drain the brine away, so not in vegetable oil. So 100 grams of tuna, a little tin of tuna has got again 20 grams of protein in it, and only a gram of fat. So those kind of foods are really useful at getting the protein in without supplementing the fat. Be careful when you look at low fat products, because in order food legislation and labelling is different in each country. In the UK, in order to be labelled as low fat, it has to be 30% less fat than the original product. So if you take something like a butter that might be 60-70% fat, you only actually need to go down to just under 50% fat for it to be classified as low fat, but it is still a high fat product. So we have to be a little bit careful with food labelling. Some things, yogurts, for instance, a low-fat Greek yogurt will have more protein in it than a plain yogurt, but it is lower in fat than the standard products, but there is still a little bit in there. But it is mainly about finding what works for the individual. If you're struggling with making food products, for instance, then things like making up egg whites, scrambled eggs can be a bit laborious. So having something like a thin crackers with tuna with a little bit of balsamic vinegar or something like that on it, just give it a bit of extra taste rather than mayonnaise and things that other people might use. So it's very, very individual. But my main caution, I would say, is just be careful with some of the low-fat labeling that goes out there, because that can be quite deceptive.
That's very helpful. So one question is, are there particular diets other than low-fat that you would recommend for people with pancreatitis? So an example might be vegan, an example might be the Mediterranean diet. And to add a bit of a twist myself, is there any evidence that certain foods that may not be high in fat are not good for people in our condition? So, for example, foods that might be inflammatory, that might have high sugar, or might be highly processed.
Okay, so in terms of specific diets, we don't really have, there isn't a chronic pancreatitis diet per se. We focus the advice we give very much on what that individual person needs. So if somebody is managing to maintain their weight and is interested very much on focusing on their long-term health, the Mediterranean diet's not unreasonable. The other things that we would look at as part of that is about optimizing bone health. So making sure that you're doing weight-bearing exercise, you're getting sunlight exposure without getting burnt, and that you're having adequate micronutrients. So from the long-term perspective, normal healthy eating recommendations are in place. In terms of other foods that might be detrimental in chronic pancreatitis, if you're going to develop diabetes as a result of chronic pancreatitis, it is because the pancreas is damaged. So a lot of people do worry about sugar content and that they might precipitate diabetes. In practice, we don't really see that. So we only see the diabetes develop when the pancreas is sufficiently damaged to do that. If your pancreas is working well enough to produce insulin, then you won't need to worry about the sugar content per se. If you're heading towards diabetes, so you've developed impaired fasting glycemia or impaired glucose tolerance, it is sensible to reduce the sugar content of your diet just to try reduce the impact that will have on you in terms of symptoms, but it won't slow down the progression of diabetes. And then processed foods, vegetarian, vegan diet, there isn't any clinical evidence to suggest that that makes any difference. And certainly for people who are struggling with eating and drinking processed foods, whilst there are some disadvantages to using them, actually we would rather have somebody managed a processed meal than nothing at all. So often we do end up by default having to use ready-made meals, microwave meals, because actually the whole of the rest of what's going on for that person means that food preparation is difficult, food storage is difficult, there might be financial aspects to it as well. So I think a very long story short, there isn't a specific answer to that. It depends very much on the individual, but the important thing is we find out what's right for that person at that time, and also accept that what's right at that time might not be right in 2 or 5 or 10 years time. So we might need to modify things.
Understood. Thank you. Next question is, do you recommend zero alcohol for people with enzyme insufficiency or with pancreatitis more generally?
So in chronic pancreatitis, in the UK, our guidelines are to avoid alcohol altogether. So there are some things where that is really difficult to achieve, particularly over Christmas and festivals. So making sure that foods that have alcohol added to them are cooked at a high temperature to evaporate off the alcohol, avoiding liqueur chocolates, those kind of things. It is a very difficult situation to be in, particularly if chronic pancreatitis has been triggered by alcohol consumption, then it is a very easy answer. But for other causes of pancreatitis, it is much, much harder, because ultimately we don't know. We have had patients over the years who have had pancreatitis caused by completely different things. So who have had very unfortunate episodes where, I had one patient a few years ago who had never drunk alcohol, had chronic pancreatitis from other causes, and she went to a family wedding and she had a drop of champagne and it triggered an episode of pancreatitis. So that was the first alcohol she'd ever consumed. So we know that the pancreas can be hypersensitive to alcohol when it's damaged, and that's the basis behind the recommendation that that people with chronic pancreatitis, regardless of the cause, avoid alcohol completely. I'm conscious that it's probably different in different countries. With regard to exocrine insufficiency and alcohol, there are lots of different reasons for exocrine insufficiency, and certainly there's no evidence to suggest that people who have pancreatic cancer, for instance, need to avoid alcohol. There's no evidence to support that. People who have recurrent acute pancreatitis should probably avoid alcohol as well, for the same reason as those with chronic pancreatitis. But those who have exocrine insufficiency as a result of other conditions, so hemochromatosis, cystic fibrosis, those kind of things, I'm not aware of any evidence to support the need to avoid alcohol completely in that setting.
Thank you. And one listener has asked that you comment on gastroparesis and its interaction with pancreatitis.
So gastroparesis is the slow emptying of the stomach, and that is a progressive condition in as much as people will present differently with it, and it can get worse. There are lots of different reasons for it. So most commonly in pancreatitis, if it occurs quickly, then usually it's because there's some inflammation blocking the duodenum. So your pancreas sits in the curve of the duodenum just underneath your stomach. So as it swells up, it squashes the duodenum closed. So if there's any acute inflammation, we'll see an acute gastroparesis. In the chronic setting, that can be due to stenosis, so that hardening of the duodenum. A high dose of opiates can also cause delayed stomach emptying, and poorly controlled diabetes or a very long history of diabetes can also cause delayed gastric emptying. In terms of how we manage it, so we have different what we call prokinetic medicines, so medicines that help the stomach empty. So we'll use those. Often liquids are easier to tolerate than solids. So if you imagine your stomach is a bit like a partially blocked sink, if you fill it with thin water, it will gradually empty, but if you fill it with solid stuff, it won't. So the same principle for your stomach. So the thinner the fluids we can get in, the better, and that's where the oral supplement drinks come in useful because they are thin. So it can have an impact on your enzymes. So sometimes taking your enzymes at the end of the meal rather than the beginning can be more helpful because there's so much acid in your stomach that the enzymes become less effective. Making sure there's plenty of antacids and that you're sitting up when you're eating, and gentle exercise afterwards. So not running or anything like that, but gentle movement just to strengthen your abdominal muscles and help your stomach empty can help as well. But it is a difficult situation, and often people will end up with a feeding tube in that setting.
Thank you. So we have one more question. I want to thank everybody who submitted questions. We had more than we were able to answer, but Mission Cure will try our best to get information out to everyone. But thank you for such terrific participation. And the last question is if you could comment on the interaction between hyperlipidemia and chronic pancreatitis.
Okay. So hyperlipidemia is the high level of lipids in the blood. So typically cholesterol and triglycerides are the two types of lipids that we measure regularly in the blood. High levels of triglycerides are a causal factor for acute pancreatitis, and they tend to be associated or found in people who have familial hypertriglyceridemia. So this is a genetic cause for high triglycerides, but we do occasionally see an acquired hypertriglyceridemia, and that's usually in people who have an undiagnosed or poorly controlled diabetes. So for instance, we will often see it when people are desperately trying to avoid going onto insulin and really struggling to control their blood sugar levels, and that can cause their triglyceride levels to climb quite sharply. In that setting, triglyceride levels do tend to drop quite quickly with a short period of starvation in that acute pancreatitis phase. But if we can't get on top of the triglycerides, then it can cause recurrent acute pancreatitis, which can lead to chronic pancreatitis. So in that setting, management with a biochemist to support the management of the triglycerides is really, really important. So making sure you're on the right medicines for that, that you're avoiding a lot of simple carbohydrates and following a low-fat diet and using things like omega-3 to control those, but under the supervision of a biochemist usually.
Thank you very much, Mary. I'm going to turn it over to Sophia to wrap up.
Thank you, everybody, and thank you, Eric, for handing it off. Thank you so much to everybody for joining us on our, I think, the second webinar of the year, if not the third one, but we'd like to give a very special thank you to Mary for joining us and for sharing her expertise and her knowledge with us. It's been a real pleasure to work with you, and I know that patients everywhere will benefit so much from the information that we covered today. So thank you so much. And if you're new to Mission Cure, welcome. We have a ton of other useful resources on our website. We shared some on the chat, some things like the PERT dosing guide. So that's a very brief guide on dosing pancreatic enzymes. And we share resources and information on our social media regularly. So be sure to follow us there and check out our website to learn more. We've also recently published some really great engaging videos. For example, we have a guided meditation for pain and a short video about medical cannabis for pancreatitis pain. So if you're interested in that, check out our YouTube channel, and it's also available on our website. And yeah, we have many other informative and educational resources coming down the pipeline, and this is part of our AbbVie sponsored patient education program. We have a webinar coming up on our cure strategy. So if you're subscribed to our newsletter, you'll be the first to know about any Mission Cure update that's coming up. And lastly, just to wrap up, we'd like to ask you to please fill out the survey. The survey after you leave the webinar, it'll automatically pop up in your browser. So it only takes 1 minute to complete, and it's completely anonymous. We'll give you a space at the end to enter your email information in case you have an unanswered question or if you want us to reach out to you. And as far as logistics go, like we mentioned earlier at the top, you will be receiving an email with a recording of this webinar as well as the webinar slides. And if you have any other questions, if you have any questions that were unanswered during the webinar, please reach reach out to us via email or via our website. We are always available. And thank you very much and have a great rest of your day, everybody.